this lesson, we're going to talk about the priorities for management and nursing care for a patient with diabetes mellitus. Now, if you haven't watched the first video in this module about the pathophysiology of diabetes, make sure you do that. It'll help all of this make so much more sense. I can't stress enough how important it is for us to know how to manage a patient with diabetes. These days, our population is sicker than ever, and many of our patients come with a set of comorbidities that I lovingly refer to as the usual. I'll get report, and I almost always hear this. The patient has a past medical history of CAD, hypertension, diabetes, hyperlipidemia, chronic kidney disease, and COPD. Oh, and also they're a smoker and they're morbidly obese. Okay, y'all, all of these conditions are going to exacerbate each other and severely shorten the patient's lifespan. So it's up to us to educate and encourage them to make the necessary changes. So let's just quickly review patho. Remember that type 1 diabetes is when the immune system attacks and destroys all of the beta cells in the pancreas. The patient has absolutely no insulin production and is dependent on supplemental insulin. In type 2 diabetes, they either don't make enough insulin to meet their body's needs, or they've become resistant to the insulin they do have, or it could be both. So it's possible that these patients need insulin if it's severe enough. Usually they can be managed with either diet and exercise or oral anti-diabetics, which we'll talk about. So what does our assessment look like? Well, of course, we're going to see hyperglycemia. Now, diagnostically, we usually see something over 126 milligrams per deciliter for at least 2 episodes for an official diagnosis. And we'll also see hyperosmolarity because of that excessive glucose. Remember, that's when you have way more particles in your bloodstream than you usually do. So it's a super concentrated situation. Both of those things, the hyperglycemia and the hyperosmolarity, is going to cause what's known as the 3 Ps, which are the classic signs of diabetes. That's polyuria, which is excessive urination, polydipsia, which is excessive thirst, and polyphagia, which is excessive hunger. Basically, this osmolarity builds up and fluids are going to start to shift into the bloodstream to try to balance out this concentrated solution. So whereas a cell normally would have some fluid in it, now all that fluid's going to disappear and the cells are going to shrivel up. You're going to see cellular dehydration. Hence, that's why they are thirsty, right? But also, now we're pulling all this fluid into the bloodstream. It's going to the kidneys. The kidneys are dumping the glucose and all of this extra fluid with it, hence the excess urination. And then, of course, the cells are not getting the glucose that they need for energy. And so that's sending a signal to your brain telling you to eat because it needs more energy. Now, the other diagnostic criteria we use is hemoglobin A1C, or glycosylated hemoglobin. That's going to tell us the average blood sugar over the last 3 months. In diabetic patients, we're usually looking at something over 6.5, and our goal with therapy is to get them under 6. Now, again, because of retinopathy and neuropathy, we might see blurry vision, they might have numbness and tingling, and then they're going to have really poor wound healing because of their decreased circulation. Remember those vascular issues we talked about? It really messes with the blood vessels and causes circulation issues and these non-healing wounds. Remember, they're super prone to this on their feet or their toes because they'll get a little ulcer on their foot and they won't know it's there because they can't feel it. And then it just gets worse and worse and worse. Now, this diabetic ulcer is actually probably one of the better ones I've seen. I've seen much worse, but it probably started the size of a pinhead. They didn't know about it. It got worse and worse and worse. And now if this continues to get worse, they're at risk for a lot of problems. So we teach patients to inspect their feet every single day and to do really, really good foot care, which we'll talk about in a second. Now, when it comes to medications, type 1 diabetics are insulin dependent. So we're going to give them sub-Q insulin. We want to teach them how to self-administer. Now, most of the time, by the time you encounter a diabetic patient in the hospital, they already know how to self-administer. But if this is a new diagnosis, we want to make sure that they're taught really, really well. We want to make sure they remember to rotate sites, etc. Now, in the hospital, most of the time, we actually see these insulin pens in the hospitals. So we want to make sure that they know how to use the specific pen that they have. Now, for type 2 diabetics, the most common classes of anti-diabetic agents are sulfonylureas. A good example of this is glipizide, or biguanides, and a good example of this is metformin. Make sure you check out the pharmacology course to learn more about those two as well as insulin. The biggest thing, though, for type 2 diabetics that's going to keep their blood sugars managed, and actually it works for type 1s as well, even though they still need insulin, is diet and exercise. They should avoid simple sugars like cakes and candy. They should focus on high quality protein and whole grains, okay? Non-starchy vegetables, things that are going to be lower in the complex carbohydrates. In some cases, type 2 diabetics can actually be wholly managed with diet and exercise if the patients are willing to commit. Now, we want to point out some of the most important and the most commonly tested things when it comes to insulin administration. First, you must know onset and peak times. We've attached a cheat sheet to this lesson that has those timings on it. I know, guys, I remember this from nursing school. It is a pain in the butt, but it is so important. You may get a question in nursing school or in the NCLEX like, you administer regular insulin at 8 a.m. At which time or during which time frame should you monitor for hypoglycemia? So you need to know that the patient is at risk for hypoglycemia during peak times. And you need to know that regular insulin peaks between 2 to 4 hours. So you're looking at somewhere between 10 a.m. and noon that you're going to monitor the patient for hypoglycemia. It's so important that you know that, not just so that you can answer the questions, but so you can take care of your patients and you can monitor them for this overreactive insulin. Another thing you need to know is that you need to rotate sites. We talked about that already. Also, in terms of IV administration, the only insulin that can be given IV is regular insulin. So if you ever see an order for something like insulin Lispro or Lantus given IV, that is not okay. The only insulin you can give IV is regular. Know that this phrase insulin reaction means hypoglycemia. I've had that on my NCLEX. I was like, I'm just going to take a wild guess because I never heard that term. So just know insulin reaction is hypoglycemia. Signs of hypoglycemia, remember cool, clammy, tired. So cool and clammy, give them candy. In terms of hyperglycemia, the way to remember that is dry and hot, insulin shot. Okay, dry and hot, give them a shot. Cool and clammy, give them candy. No, don't ever use expired or cloudy insulin unless it's meant to be cloudy, like NPH. Now, also make sure that you know how to mix clear and cloudy. Remember, it's always clear before cloudy. There is a fantastic video on insulin within the pharmacology course, so make sure you check that out. He actually explains and goes through an example of how to mix clear and cloudy, so make sure you know how to do that process. It's actually a really common drag and drop ordering question on the NCLEX. Now, top nursing priorities for a patient with diabetes. The number one things, well, really there's two: skin assessment and sugar management. When it comes to skin assessment, we need to do a really thorough skin assessment, especially on their feet. I mean, look between the toes, under the toes, their heels, etc. Guys, you must take off the patient's socks. Look at their feet. It is so important. We also want to make sure that we're doing meticulous wound care for any wounds they do have. Keep them clean, keep them dry. You can always consult your wound care specialist nurse. Sometimes they're also called WOCN, which stands for Wound Ostomy Continence Nurses. Make sure you check with them. They're going to give you specific wound care orders that you need to follow. And it is so important with these patients because we are their last line of defense against this really awful wound that can end up being life-threatening. We also want to be prepared for any kind of hypoglycemia management. Sometimes patients just respond a lot quicker or stronger to insulin than we expect. So remember Cool and clammy, give them candy. Make sure you've got orders for hypoglycemia management. So what we do is we use the 15-15 rule. We're going to give them 15 grams of sugar in some form. This could be 4 ounces of juice, or it could be like 5 pieces of candy. And some places will even have a glucose tabs or a glucose gel. Whatever your facility uses, make sure you give them 15 grams of sugar, and then you're going to check again in 15 minutes. Okay, so recheck in 15 minutes. Give them 15 grams, recheck. Now remember, hypoglycemia can also cause decreased LOC. So if they're not alert enough, then what we're actually going to give them is something like a half an amp of D50 IV. We don't want to put anything in their mouth if they're not alert enough to swallow. And again, we want to prioritize really good foot care, keep their feet warm and dry, wear foot protection at all times, don't wear socks that are too tight. Again, this is so important because they may have neuropathy and not be able to feel their feet. So patient education is super important. We've attached a really detailed list of patient education topics, including details on foot care, to the outline of this lesson. So make sure that you check that out and know how to teach your patients. So, as you probably could have already guessed, our top nursing concepts for a patient with diabetes mellitus are going to be glucose metabolism, tissue skin integrity, and patient education. Check out the care plan attached to this lesson to see more detailed nursing interventions and rationales. So let's recap. Diabetes causes hyperglycemia, which causes damage to the vessels and nerves because of the inflammation and hyperosmolarity. The classic symptoms of diabetes are the 3 Ps: polyuria, polydipsia, and polyphagia. Type 1 diabetics will require insulin, whereas type 2 diabetics could use an oral anti-diabetic agent or even just diet and lifestyle changes to manage their sugars. You have to know the insulin precautions that we talked about. This is the number one medication error I see in students, new grads, and even older nurses. And I even made an insulin error myself when I was on orientation. So stick to the basics of med administration. Follow the safety things we talked about. Follow your 5 rights and you'll be fine. And then remember, meticulous skin and wound care is imperative. We want to prevent those wounds from spreading, prevent them from becoming infected, because ultimately the only option for them becomes amputation, and we want to try to avoid that. And of course, educate, educate, educate. All right, so those are the basics of nursing care for diabetes mellitus. Make sure you check out the DKA and HHNS lessons to know how to manage acute exacerbations of diabetes. And don't miss all the resources attached to these lessons to help you learn more. Now go out and be your best selves today, guys. And as always, happy nursing.